Yep. Welcome to the CyberHealthPodcast. I'm Stephen Pirano, your host, a.k.a. Napoleon Dynamite. This is our Halloween episode. This is Dr. Simon Buttrick, neurosurgeon.
It's Buttrick. But
Buttrick.
everyone gets it wrong. I've heard everything
wrong,
from
right.
Buttrick to Buttricks.
Right. So it's Buttrick.
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 You got to lean into the uncomfortableness of the butt.
Okay, so it's Buttrick.
Yes.
For you guys at home, it's Buttrick, Dr. Buttrick. Okay. And that's an interesting name. Where are you from, New Jersey?
Not quite. So I grew up in Switzerland.
Wow. Switzerland. Okay.
My dad's from Philly. My mom's Swiss. So the name is American or English or something.
Right.
But yeah, I grew up in Switzerland.
Nice. Beautiful. Well, welcome. So how long have you been here now in the U.S.?
So I came to the U.S. for college when I was 18. So it's been 19 years.
19 years. Wow. Okay.
I just hit the halfway point of my life being here.
Right. That's awesome. Well, we're glad you're here. So what inspired you to get into medicine?
So I don't know exactly, to be honest. When I was a kid growing up, I never really thought about medicine. I was always kind of a sciencey kid, so I just figured I'll do physics, engineering, something like that. That was all in Switzerland where I grew up. And there was nobody in my family in science or medicine or anything even marginally related to that. And then I went to the U.S. for college, and there was a kid in my dorm who said he wanted to be a doctor, and I started thinking, that's kind of an interesting idea. You sort of get a little bit of sciencey, but also, a lot of human interaction, a lot of just life. And I was like, that's not the worst idea. Let me think about that. And that kid ended up failing organic chemistry.
Right.
And he, I think, ended up writing vampire novels or something like that.
Oh, wow.
But I kind of went down that track and never really looked back.
Nice. So you mentioned that you're originally from Switzerland.
Yeah.
That's interesting. Well, one thing real quick, I do want to tell people at home that are watching, we're doing something different on this episode. We are doing a beta test, and we have a few users online right now that are able to send questions in so they can be a part of the podcast as well. You mentioned Switzerland, and they're asking, have you ever been to Davos, Switzerland?
I have.
You have been, okay. And the question is, okay. So if you've been to Davos, Switzerland, then you might be familiar with certain meetings they have there once a year. Is that
Vaguely.
Vaguely.
I was never there during the meeting, but yeah.
Okay. And just so we make this clear, the meetings we're talking about are the World Health Organization. Have you been to a World Health Organization meeting before?
Can't say I have.
You can't say you have, okay. Does the World Economic Forum ring a bell?
Same thing. Rings a bell, but never been.
Never been. Okay, and lastly, the Bilderberg Group. Does that mean anything to you?
Can't say it does.
Okay. All right. Well, thank you so much for that question to our guest. He appreciates the question. You appreciate those questions?
Absolutely.
Okay, great. So keep them coming in. But now back to the interview. Seriously, though, so we understand that, you got into medicine really by a friend, right? Kind of like
Sort of, yeah.
Coercing in a sense. But why neurosurgery?
Also kind of random. I read a book back when I started thinking about medicine called Saturday, where the main character is a neurosurgeon. And again, it just sort of gave me like a first look into the field, even though it was a novel. Right. But I was like, this sounds interesting. A lot of variety. You treat so many different pathologies, different parts of the body. Sounds interesting. And then it turned out that actually the mom of one of my high school friends was the head scrub tech at the neurosurgery department at the University of Zurich.
Wow.
So I went home over Christmas break one year, and he was like, hey, why don't you just go and watch a case? And so I went to the OR for the first time there, and that was it. I was
nice. And what kind of case was it?
It was a glioblastoma, so a malignant brain tumor. Right. Something that now, if I look back, not the most exciting or inspiring case we do, but still just,
sure.
Seeing the brain for the first time, that's a it's a pretty big deal.
Sure. Yeah, because you specialize in the head and back surgeries for people who are not familiar with neurosurgery. So can you explain a little bit about exactly what it is that you do? What's a typical day-to-day?
Yeah. So I think the beautiful thing about neurosurgery is that it's so broad. And a lot of people subspecialize, and I do some of that, but I try to still do the majority of our field. So sort of the big disconnect is between cranial neurosurgery, so the brain, and spine. In addition to that, you have, functional neurosurgery, which deals more sort of with adjusting the function of the nervous system in several ways. And then peripheral nerve, which is very rare. So the two big camps are really cranial and spine. And depending on what you're doing on a given day, it can be just wildly different. You can be doing spine one day and putting screws into somebody's spine and doing, heavy sort of labor-intensive physical work. And then the next day, you're doing the most delicate, intricate operations under a microscope, seeing tiny little 1 millimeter nerves and arteries. So it's just a very broad spectrum of what you can do.
Sure. Wow. And is there any particular case that you prefer over another that you enjoy doing?
There's a couple. So, a lot of this I think is just personality. There's some people who are drawn to just doing the most complex, difficult, long operations because, not a lot of people can do that. And when you're done, you kind of feel a real sense of accomplishment. I never had that personality trait. So I think the things that I tend to enjoy the most are sort of the quick, elegant things that actually make people feel better. So microdiscectomies, which is sort of a poo-pooed case, It's one of the earlier things you learn in residency. Basically just means you usually do it through a tube nowadays. You put a tiny little tube down to the spine to remove a herniated disc. It takes like 45 minutes or an hour. It's not terribly complicated, but there's still, there's people who are good at it and there's people who are bad at it. And you can make a huge impact on somebody's life. On the cranial side, there's something called a microvascular decompression, which is for patients with trigeminal neuralgia, which is this condition where you get just debilitating pain shooting into your face. And in most cases, that's caused by a blood vessel pushing on a nerve, the trigeminal nerve. And so you just do a very small opening right behind the ear. You get down there, find the nerve, push that vessel away from the nerve, put a piece of Teflon in there to create some space, and that's it. Again, it takes maybe an hour and a half or so. Right. And usually patients wake up and they're essentially cured. So huge impact on somebody's life. You kind of feel good about yourself. Patients are happy. So those are the kind of things that I like.
Oh, that's great. And for patients that perhaps unfortunately have to undergo maybe a procedure with you, is there any kind of tips or any suggestions you can provide for them that maybe they miss in your appointment, when they're doing the pre-op and you're talking to them about the surgery?
Yeah, that's a good question. So it depends. I think for spine, the biggest thing, there's two things. One, you just want to get in the best possible shape you can. A lot of people who have spine surgery get to that place.
He says that as he's staring at my gut. Thank you so much. Okay.
Exactly.
Right.
I was looking at you there. A lot of people get to that point that they need spine surgery because they've neglected their bodies for many, many years. So trying to, get to a better weight, being as mobile as possible before surgery, just so that your rehab's not going to be as rough. And then just knowing that you're going to hurt. Spine surgery, for the most part, and there's different types of surgeries we do, but sort of classic open lumbar spine surgery is very painful. Mm-hmm. And there's tricks we can do to kind of mitigate that, but it's still going to hurt. So the more people are aware of that, I think it tends to help. Mm-hmm. For brain stuff, it's very hard to sort of generalize. One thing I think is that people tend to overestimate how rough it's going to be. Cranial surgery has risks, for sure, and you see far more truly devastating outcomes in cranial surgery than in spine. But for the most part, people do pretty well with this stuff. And there's a lot of people who go home the day after surgery, and, they're not going to feel like running a marathon.
Sure.
But a lot of them do fairly well.
So what's a typical OR day for you? Like starting from going in the morning.
Sure. So for me, like my usual sort of workflow is I'll come in the morning, sign in my patient for the day. Then the team takes the patient to the operating room, starts intubating and all that stuff. While they do that, I'll usually go around and grab some breakfast. And then I'll come in, do the case, whatever that may be. And then when you're done, if there's a second case, same thing repeats. Usually grab some lunch if you can. And then when you're done, you get out of here.
So what's one thing or many things that you appreciate about the OR and specifically the OR team? How does that help you?
Yeah, I mean, neurosurgery and I think all surgical fields at the end of the day are very collegial. Like you need a good team. And I think people underestimate how much that matters. Like when you get paired with scrub techs or nurses or anesthesiologists you've never worked with before, it is painful. Whereas if you're with the people that you've worked with 100 times before, they know your workflow, things go so much smoother. Especially, things go faster. I gotta think it has some effect on patient care too, probably less so than just the speed of everything. But if you're gonna do, thousands of cases, eventually it'll matter that you've worked with a team that you're familiar with all the time.
Sure. And is there anyone in particular that you work with consistently? Because I honestly, I don't think we've ever worked together.
We haven't.
Right? Yeah.
So we have Maria. She's one of our scrub techs. She's phenomenal.
Hey, Maria.
Hey, Maria. Yeah, Maria Suarez. She's excellent. She's been doing neuro for, decades. She's one of those people who she knows what you want before you even really tell her.
Right.
Or if you tell her the wrong thing, she gives you the right thing.
Right.
Because sometimes I mumble and sometimes I'm too focused on what I'm doing and I'll just say something random. I'm like, what? That's not actually what I wanted.
That's awesome.
So there's her and then Sue. She's one of the CRNAs.
Oh, nice.
Who, honestly, I would pick her over most anesthesiologists.
Right.
Because she...
No offense, Dr. Clifford.
Yeah.
He's watching. Okay, no offense.
I know he is. I actually saw him watching his own podcast episode earlier, but we'll skip that. We'll edit that out.
No, we appreciate the views. Thank you so much. See?
So yeah, she's excellent.
Sue, yeah.
She's done, hundreds of neuro cases.
Right.
And you just know if you have her, you don't have to micromanage every single thing. She knows that the blood pressure has to get controlled. She knows that the CO2 levels have to be at the right place. All these things that if you have anyone else, you have to specify everything.
Right. So continuity plays a big role in the operating room.
Huge.
That's great. So now, I'm assuming that you do have residents at
we
times.
Don't.
You do not have residents.
No.
Oh wow, that's interesting. Why is that?
I mean, we're a community hospital at the end of the day. I think we're a big academic-ish community hospital, but still we're not like University of Miami or something like that.
Right.
There has been talk for a while of getting UM residents up here for a rotation, which I'm all for, but that's not going to happen for a while.
Okay, all right. And now, speaking back when you were a resident, is there anything that you could think of that perhaps comes off the top of your head that it happened to you and you're like, wow, I know I'm home, like this is what I'm meant to do? Usually people say in residency something happened where it switches, and you're just like, yeah, I made the right move.
That's a good question. So I can tell you, let me backtrack a little bit.
Sure.
I, up until residency, never felt like I really struggled at anything. Like high school was pretty easy. College and med school, fairly easy too. And then I got to residency, and I remember very distinctly, there was this one moment I was walking back from clinic, because one day a week we would do clinic at this other building on campus. I was walking back from clinic back to the hospital to, catch up on work, and I would just look at my list of things that I still had to do, and I almost broke down. I was like, there's just no way, because especially as an intern, you just get loaded with all these things to do, which now looking back, most of these things didn't really matter and kind of get done on their own. But you're sleep deprived, sleeping 4 or 5 hours a night, if that, working way too hard, at least subjectively it felt like that. And I actually feel like I did mainly stick to that 80-hour work week that they, try to get residents to stick to. But still, it's rough. And so I had this moment where I was just like, there's no way. I can't do this. I think I called my mom, and she told me like years later, like, I heard something in your voice that day. Like that was not right. And then that passed, and after a couple of months, you start feeling like you know some things. You suddenly start feeling like, wow, I don't know why, but I know how to manage these things now. And then as time goes on, you start going to the operating room, and that's, I think, when you really start feeling like you're doing something. So as in my 4th year, so neurosurgery residency is structured in different ways depending on where you are. What we did is we would do clinical rotations for 3 years. And then you have 2 years of sort of elective time or research, and then your final 2 years where you sort of, try to get ready for practice. And as my 4th year, I did a brain tumor fellowship. So that was kind of the first time I would sort of get to independently operate and really feel like I'm doing something. And I think that was the first time I sort of saw, I think I'm actually pretty decent at this, because before you don't know, right?
Sure,
You're on the floor in the ICU taking care of stuff, writing notes, just transmitting information from one person to another. Like a patient gets sicker, you let the attending know, the attending tells you what to do, and you're just kind of this intermediary. You don't really feel like you're doing anything. And you know that what you're doing doesn't really correlate with being good at neurosurgery in the end. But then once you start operating and actually doing things, you start to notice, whether this is something that works for you or if it doesn't.
Right. So you think that, as you mentioned, those mundane things, were they getting you ready for something in a bigger picture?
I think in a way, I think it's a little bit of like a Mr. Miyagi kind of thing, Like you're doing all these things that seem mundane, like writing orders 18 times for a subarachnoid hemorrhage, for example, when somebody has a ruptured aneurysm. And you do the same thing over and over again, and suddenly you're like, oh, I know how to manage these things now. Just because I've been told what to do 18 times, and I've written it on the chart, because we still had paper charts at that point. And now I know, and it's suddenly easy. And these terribly sick patients come in, and you don't really feel nervous or anxious because you know exactly what to do. So there's definitely something to that, but it was painful. No way around that.
Sure. Well, if you don't mind, we're going to go to one more question here from the chat. And someone said, do you have any advice for residents? Although I know you don't get residents yourself, but you obviously were a resident at one point. Do you have any advice looking back on just like the sentiment you just shared?
Yeah, I have lots. I don't know where to begin. Okay. So number one, I think, is just finding like a sweet spot between caring but not getting completely enveloped in what you're doing. Because I think there are people who sort of paralyze themselves because they are so worried about every single little thing. And yes, you have to be meticulous. Yes, you have to make sure you don't make a mistake. But you also can't just be completely paralyzed by fear. So, as a resident, you have to operate, and you have to push your boundaries a little bit occasionally. And you definitely have to do that in a safe way as much as possible, but, you need to do things. Right. So that's one. And then on a very different angle, I think it's very important to think about what you want out of this, like what you want out of residency and what you want to do with the rest of your life. Sure. So if you think you're going to go into academics, you should, tailor your residency accordingly and do research and focus exactly on the kinds of cases that you want to do. If you want to do more something like I'm doing, which is more of like a broader community type practice, you got to learn everything, right? And probably not focus so much on research. And then also think about sort of the exact setting that you want to work in, because there's huge differences in your life depending on whether you work in private practice or an employed model like where I am, or academics or anything like that.
Okay, that's great advice. You have a little bit of background in playing basketball. Now, how has basketball influenced your teamwork abilities, I should say?
Yeah, good question. So, I think I was never a terribly competitive person. Definitely playing basketball, and I think same now. So I think I try to, get along with the people I work with. There's very few people that I really just cannot find a way to get along with. It's happened for sure. But I'm always a little bit taken aback when that happens. So I think the big thing for me is just kind of joke around with everybody, have a good relationship with people.
Yeah.
I just don't think I have the personality to be like the kind of surgeon that throws stuff around and makes a big deal. I get annoyed by things the way everyone does, but I'm not the kind of guy that's gonna write you up or
right.
get petty like that.
We're calling a Delta. Okay.
Exactly.
Right.
Exactly.
Still get an email.
Still have not done a Delta.
Right.
Just jokingly.
And honestly, and I appreciate you saying that. Like I said, we don't know each other that well, and I definitely haven't worked with you. But to hear you say that, it's good to know that with all your education, with all your experiences, you're still humble, you're still a person, and you treat people with respect, because we work in a very stressful environment, right? It's a level 1 trauma center. You have an idea what your day looks like, but you never know what it's going to end up. And so by you saying that you don't fly off the handle and you're able to keep your composure in surgery, it's great. It's a great skill. And I think it's something that we want to promote on this channel, because there's unfortunately still some physicians and other professionals that are not physicians that don't know how to talk to people correctly, professionally, but more importantly, they're not able to keep their composure and critically think in stressful situations. And that really comes out and shines when we're in those situations, and you can see someone and how they handle pressure. So I commend you for that. And that's one reason why you're sitting across from me, because I talk to people and they say you are a nice guy, great to work with, you care about your patients. So we do appreciate you. You're an asset to the hospital and to humanity.
I mean, I'm definitely far from perfect on any of those things, but we're trying.
Yeah, you're trying, right? That's all we can do. So another question. Now, I have some other questions here. Let me get them on the phone that I thought of. Let me just pull it up here. Okay. All right, so now we're going to go to a serious question here. These are serious questions. Neuralink. Do you know anything about Neuralink?
A little bit.
Okay. And the little bit that you know, what would you say if someone who doesn't know what Neuralink is?
So essentially, it's an implant that goes into the brain that can pick up signals from single neurons, so brain cells, and then transmit that signal to a computer and use that signal to do any number of things. And I think it's been probably a little bit overhyped. It's very cool what they're doing. There have been attempts to do very similar things for years. I was an undergrad at Brown, and they actually did one of the first sort of brain-computer interface experiments there, where they implanted a device that was, definitely not as high-tech as Neuralink, but same idea. Like, you would put a chip in the brain. There was actually a cable that went through the skin, so there's always an infection risk with that, and Neuralink has kind of gotten around that problem by just transmitting the signal with Bluetooth. So the technology has been gradually building over many years, but it is pretty impressive what they can do. So the first patient who got the implant, he can definitely control a cursor now. Not quite as well as you and I with a mouse, but pretty decently. So you can play video games and stuff like that. So obviously, very early sort of steps, but the idea is that eventually you want to be able to get a quadriplegic person to, control a robot arm or a computer really fully the way you and I do, or then eventually, maybe have some kind of stimulator in the rest of the body that can then make your muscles move again. That's many, many years away, but we got to start somewhere.
Right. So from your understanding, it's a positive thing.
Oh, for sure.
Right.
Yeah.
Or at least that's what the inception is of the idea for Neuralink is positive, right? To help people. Okay, great. We appreciate your honesty. And now going a little bit away from Neuralink, but more or less in the same arena as far as, hype. P. Diddy. Have you ever been to a P. Diddy party?
I wish.
Okay, he wishes. There you go. Okay, well, at least you're honest. Okay. As we understand it here, we do some dirt digging, and we did... confession, I did know that you were from Switzerland, so I did some research, and what I found was that you were known for a famous underground break dancer.
Really?
Is that any truth to that?
Me personally, or the
Yeah,
Swiss?
you personally.
Again, I wish.
Okay, he wishes. Well, he's not admitting to a lot of things today.
I'm not Ray Gun.
Okay. And finally, for the bonus questions, I do understand that you are an exceptional pianist.
I wouldn't go that far, but I'm okay. My dad was a pianist, so he taught me. And I definitely never sort of thought about doing it professionally too. But I've always kind of stuck with it. I think the big thing my parents did, they're both musicians. My mom's a music teacher. My dad was a pianist. And they never forced us to do anything. So I just kind of sat down at the piano one day when I was like 6 and liked it and stuck with it. But never, I was never forced to practice or play or do recitals and all this stuff. And I still enjoy it to this day, which I feel like a lot of kids who sort of get forced to play an instrument or the piano, they'll do it because they have to, and then the moment they don't have to anymore, they quit. And then years later, they all regret it. Right. But I've kind of stuck with it. It's fun.
That's
good,
great.
Good balance.
Yeah. That's funny. In the chat, it says, prove it. Prove it. All right. Well, we got to listen to the guest. So here we go. It just so happens that we do have a piano here. And we're going to go ahead and no pressure.
Let's see.
Get it in here. Get it all worked up in here. Okay, we're going to get it all worked up. And you know what? Let's see. Here we go. Let's get out of here real quick. And all right.
Let's see.
Go ahead.
Oh, nice.
Check it out. There you go. Let's see.
It's not quite the right. Doesn't go all the way
That's
down
awesome.
either.
Well, let me join you. I brought
Nice.
a harmonica here. Okay. And here we go. Go ahead.
What do you want me to play? Oh, let's do something that everyone knows.
This is an exciting part of the episode. This is the part where we like to mention our sponsor. And the sponsor today, let me put it here. The sponsor today is Poopery. So if you guys at home and ladies are not familiar with Poopery, this is something you spray before you have a bowel movement. And this particular one is Cherry Blossom. So you can have your whole house smelling like cherry blossom. That's Poopery. We thank you so much for our sponsors. This is amazing. All right, now we're going to get back to the serious part of the podcast here. So, with your career that you have in medicine and surgery, as you described, it's very demanding. Could be long hours. So, how do you manage work-life balance?
The biggest thing is definitely just my wife. So we met when I was a second-year resident, so we've been through pretty much this whole journey together. She's a dentist, but she trained in Venezuela initially, so she kind of had to redo her whole training here too.
Wow.
So we went through my training, her training, a kid, twins, everything together.
Right. You have phenomenal teeth, by the way.
Oh, thank
Very
you.
nice. Yeah, I need to see her.
That was not her. That was my orthodontist back in Switzerland. I had messed up teeth as a kid, actually.
We have a picture. It's up right now. We can show there, right there. It's a side by side. Perfect. Okay, great.
So yeah, she's been extremely supportive. Her parents are doctors too, so she kind of knows the deal.
Sure.
But she's been super supportive, and don't think I could have, made it to this place without her. So that's definitely the biggest thing. Another factor, I think, is just sort of my mindset. I'm not one of those guys who wants to sort of have neurosurgery be their whole life. And there are those people, and that's fine too. Like, we need that. I think those tend to be the people who really move the field forward. But that's just not me. I don't want to be one of those guys who retires when he absolutely has to at 75 and then realizes there's really nothing else he enjoys, you know? And I definitely feel like I trained with people like that who were phenomenal professionally, but then just didn't really have a whole lot else to go to after their career. So I try to, you know, cultivate other interests, playing piano, cooking, snowboarding, sports, my kids, my family. So I think that was the biggest thing for me.
Sure, yeah, that's great. And as far as the demanding or the demand in the operating room for the length of surgeries and the complexity, did that ever come to play when you were looking at what field to enter? Did that ever come to mind?
Not significantly. So, like I said, I was kind of set on neurosurgery from the get-go. When I was in med school, I actually flirted with a lot of other fields. I did medicine and was like, oh, this is interesting. I could see myself doing cardiology or something like that. I did ENT, which I really liked. And the people were much nicer in ENT than they were in neurosurgery, at least where I did med school. So for a while, I kind of tried to convince myself to do ENT because everyone would tell you, don't do neurosurgery unless there is absolutely nothing else in the world that will give you even a little bit of joy, you know? And I think that's a way of thinking that was appropriate 30 years ago, maybe, when the lifestyle was really just crushing. I don't think that's really the case anymore. So could I be happy doing something else? Sure. You know, I think I could be happy being a cardiologist or an ENT or a number of other things, but this is definitely the best, in my opinion.
Awesome. You've been recorded before of saying this particular procedure is a high sphincter procedure. What would categorize as a high sphincter procedure?
Oh, that's a good question. So I think there's two very separate categories. One is just things that you haven't done a ton and aren't familiar with. So when I started out in practice, I started doing carpal tunnels, which I had done a handful in residency, but not a ton. And it's the easiest surgery we do. And the potential for complications is very, very low. And the first couple times I did one in practice, I was still way more nervous than doing some massive brain tumor just because I felt comfortable with that, you know? I've done a lot of big brain tumors. That's routine. But even a 5-minute carpal tunnel gave me way more anxiety. So that's one. And then the other is just any case with significant potential for devastating complications. So one relatively common case is an acoustic neuroma. Those are benign tumors that come from the eighth nerve, which is the nerve right behind the ear that controls hearing, balance, and also is right next to the nerve that controls your face. And so it's one of those cases where no matter how good you are, every now and then you're going to hurt somebody's face and leave them, you know, looking like they had a stroke, which is a huge deal, especially for a benign disease, right? So it's one of those cases that's great when they go well, but very much not if something happens. And again, it's one of those things, if you do enough of them, it's unavoidable that occasionally it's going to happen.
Right. Yeah, that's what I hear. I hear that, like, if you haven't gotten to any kind of mishap in the OR, you're just not doing enough surgery. It's bound to happen.
For sure.
Yeah. Speaking of that, I also did some digging on your background in medicine, and what I understood was that you initially wanted to be a chiropractor, but you couldn't pass the exam, so you went to neurosurgery.
That's what happened. Yeah.
That's pretty much what happened. Okay. Well, at least he's honest, folks. He's honest. Going back to Switzerland, I understand that you guys have some interesting dishes, food dishes. We spoke about something with potatoes.
So, I mean, everyone knows about fondue, which I'm not going to lie, I haven't had in 2 decades. And I didn't particularly like it when I had it, but maybe that would have changed. So I got to try that again. And then the other big one is raclette, which I'm a big fan of. So basically, it's melted cheese that you put over boiled potatoes. Sort of the real traditional way to do it is that you have the actual wheel of cheese, and they melt it under a flame, and then they bring the whole wheel of cheese to your table, and then they scrape it off.
Wow.
It's delicious. There's a home version of that where you get like a little oven. They actually sell it at like Marshall's or something for $100 maybe. And you have these little pans that you put cheese in, and you just stick it in the oven, and it heats it up. It's great.
Oh, wow. All right. It's good to go.
Great for your heart, too.
Great for your heart. Yeah, I bet. What else we have here? We saw a couple clips. The hospital did some promo videos about you. It was really cool. That's when I saw them. You like to exercise. So what would be any particular exercise you like to do over another, or an exercise that you could share to patients or something that can help them improve their quality of life?
Good question. So I've been trying to exercise more recently. We had, like I told you, twins 10 months ago.
Right.
So it was rough for a good while. We're finally in a place again where, things are a little bit more manageable.
Sure. You look great.
Right back at
You look like the lead singer from Coldplay. Anybody ever told you that?
Chris Martin?
Chris Martin.
Never heard that before.
Yeah, you look
Interesting.
What are you doing later?
I'll take that.
You're busy? Okay.
So as far as specifics, right now I'm trying to lift like 3-4 days a week and then do some sort of cardio the other days.
Like driving a lift?
Exactly.
Okay.
Yeah.
Yeah, no, I did see you were squatting with the bell there, the dumbbell. What is it? The barbell? What do they squat with?
I think that was dumbbells, but
Dumbbells, yeah.
I do like squats actually. Not that I'm good at it. I'm a pretty scrawny guy, and I was never super athletic as a kid, but I do feel like it just makes you feel better.
Yeah.
And you definitely get stronger over time, which, I think we're learning more and more that just being stronger gives you a much better chance of having a long and good life, because you can still do things when you're 80.
Right.
I have an uncle who's, I think he's got to be like 85-ish, and he still skis like 100 days a year, hikes, crazy, and he's perfect, So I think that's kind of the goal. I don't want to retire and then be bedbound right after.
Right. No. And speaking of beds, you strike me as the kind of guy that you sleep on your back. Are you a back sleeper?
I'm a front sleeper, 100%.
Front sleeper, 100%. Yeah, because I understand doing my research in Switzerland that's typical. Everyone sleeps front. You have a chance to get up.
Yeah.
Easier.
The Germans, it's the opposite, but the Swiss for sure.
Right. Okay, that's good. See, so we're getting accurate information here.
Science.
And, one last question here from the chat here. They're saying, on a typical Friday night, what would you be doing if you didn't have the 2-year-olds? Like, let's go in back sense. What's a typical
Good
Friday
question.
night for you?
I barely remember. I feel like I haven't done anything fun in a long time.
In a couple years.
But that's okay. There's other types of fun. I mean, our big thing was just eating.
Eating, yeah. Right now, what is it? Teletubbies? What do you got? What are the kids into? 2-year-olds, I remember.
There's actually a great show on Apple called Stillwater.
Stillwater.
That our daughter loves. That I actually don't hate, because all the other stuff is such garbage. Jesus Christ.
It's hard to get through.
Oh, the Mickey Mouse. Like nails on a chalkboard.
So have you been to Disney lately?
Never been.
Never been. Okay, there you go.
So
not planning on it. Right?
Funny story. So my dad, who passed away about a year ago, he was significantly older. It was it was expected. Still very sad, but expected. But he had 2 kids from a prior marriage, and he took them to Disney, and just hated it. I think it was the worst experience of his life, and so he just never took us. And then by the time I could have gotten interested in Disney and knew about it, I was already too old, and so I've never made it, which I'm totally fine with. And now I'm trying to just hold off as long as humanly possible, because it sounds awful.
Right, and it's a whole ecosystem of
the lines, the food.
You can use that's a whole episode just on. Hey, but it's a business like anything else. But you're right, they get to when they're young, and indoctrinate them. But hey, that's smart though, because you are saving a lot of time and money.
I know,
right, on those theme parks and the cruises.
Also, I always feel like you can give a kid like a cardboard box, and they're going to have a good time.
Right. It's the imagination,
Yeah.
right? Yeah, that's true, because I think with all, although I have seen, of course, Disney movies, I've been to Disney before, but yeah, it's like, I think we're at the time now where technology is so inundated in everyone's life, regardless of your age, that your opportunity to have an imagination, especially for a child, is suppressed, right? So like you said, with a box, here's a box, let's have some fun, let's figure something out, or even going outside for that matter. My 14-year-old stepson, nothing against him personally, but that generation, they just, they're inside. It's
not their fault.
It's not their fault. And it's, hey, you go to your friends, we're going to go outside. No, we're going to hang out inside.
Yeah.
But, it's good for the skin, I guess. The dermatologists hate it because it's creeping up on their business. Right, yeah, their bottom line. For you as a surgeon, when you walk into an operating room, is there anything at this point in your career that, besides the staff themselves that you're not familiar with, but anything else that you may be looking for or that you notice and that could affect your surgical outcome?
Honestly, not really. I mean, I think at this point, when you get into the OR with the technology that we have, you know what you're going to see.
Got it. Okay.
So you know what to expect. There's few surprises. It happens, right?
Sure.
Sometimes you'll see tumor somewhere where you weren't expecting it, and
Right.
you'll have to adjust your plan a little bit, but that's fairly rare.
Okay.
So nothing where you like walk into the OR and you
just totally like shell shock, like, oh my God, what happened? Okay.
Yeah.
So then, speaking about technology, let's wrap it with that. So how does technology play a role in your career?
Sure. So there's, let me take a step back. So there's a very different story in spine versus cranial there. For the most part, cranial surgery has been very much a technique-driven field. Technology plays a role for sure. Operative microscopes have been around for 50-ish years. That was obviously a huge step up. If you can't see the things you're trying to preserve, that's a problem. So microscopes are huge, and they've obviously gotten better, but there hasn't been like a step function change in a while. Neuronavigation, which basically lets you register the patient's head to a scan so you know exactly where you are, that's a big deal. But again, that's been around for probably 15 years, and it's gotten sort of incrementally better every couple of years, but no big step function changes. And in spine, we're also moving more and more from using x-rays to using navigation. So you'll do a CAT scan on somebody while they're on the table so you can navigate and know exactly where you are and put screws in the perfect position as opposed to using x-rays. So that's great. That's definitely made my life a lot easier. But none of these things are sort of complete game changers. There's a lot of talk of robotics, which has never made a whole lot of sense to me. So there are robots now that let you essentially pick your trajectory for a screw on a computer, and then it tells you exactly where to go. But putting screws is the easiest part of the surgery anyway. So you're kind of helping the part of the surgery that nobody's really worried about it anyway. Have we seen misplaced screws? Yes, but it's very rare, even with x-rays, even freehand, which there are some places where they'll place screws without any sort of image guidance, which I was never trained like that, so I don't really do that, but it's very doable if you know the anatomy well enough. So even with that, having a misplaced screw is fairly rare. So I feel like a lot of this stuff is kind of focusing on the wrong issue. It definitely helps bad surgeons, right? If you don't know what you're doing and you have a robot that can tell you exactly where to go, that helps. But if you're a half-decent surgeon, I feel like the benefit is fairly limited. And then same with all the other spine hardware. We make incremental progress every couple of years. There's expandable cages now where, when you do a discectomy on somebody before doing a fusion, you'll usually put a cage in there, which essentially takes the space of the disc to stabilize everything. And they have expandable cages now, which you can put in at a small height and then make them bigger. It's very nice. Definitely makes your life a little bit easier. Is it a complete game changer? No. So I think sort of the big things on the horizon, augmented reality is going to be a big deal at some point. It's around, there's people toying around with it. So for example, you can merge the neuronavigation system that we're using with augmented reality of some sort. That's definitely going to take off at some point, but I don't think we're there yet. I don't think that's really of any significant use yet. But then for me, because I'm mainly a tumor guy, the big thing I'm holding out for is, new treatments for malignant brain tumors, because that's really an area where we've barely moved the needle over the past couple decades. So if you're diagnosed with a glioblastoma, like John McCain had and all, somehow all these politicians get them. But if you're diagnosed with a glioblastoma, the average survival is somewhere around 15 months. And, we've changed that a little bit. So there's a medication called Temodar that's improved it a little bit. Radiation helps a little bit. But none of these things have been game changers. And I do think somewhere over the horizon, there's going to be something that really changes things. And we get excited about something new every couple of years, some new type of targeted therapy or immunotherapy or virus. And there's a lot of excitement. And first trials look promising, and then they do bigger trials, and it doesn't work. So we've been led astray many times and gotten excited about something that didn't work in the end. But I think sooner or later something's going to work, and that's going to be a game changer. Like that's the thing I'm excited about. The other things are fairly incremental, I think.
Wow. Well, thank you for sharing that. And speaking of different procedures, what is your opinion about kyphoplasties?
So I don't do them. I think there's a role for them in the right patient. There are definitely patients who feel a lot better almost immediately after. I just don't particularly enjoy doing them. We have a partner who likes doing them, so we'll send them to him. But definitely in the right patient, it's a great procedure. Sure. It's very overutilized in this country because it pays well. If you do it in the office, sort of in an outpatient setting, it pays very, very well. And generally things that are lucrative, they're going to get overdone. So we definitely do way more kyphoplasties than we should. But there are, for sure, patients who benefit.
Now, can you share a memorable surgical case that impacted your future?
Sure. There's a lot to pick from. Let me give you a bad one first.
Okay.
Because I think those always stick with us a lot longer than the good ones, and then balance it out with a couple good ones. So I think the first time I kind of came in touch with sort of the severity of what we do, I was a third-year resident, which means, I had done enough to kind of build up some confidence, but at the end of the day, I was still pretty clueless. And I was on call, and there was a patient who had some benign brain tumor taken out a week ago or so, was doing fine. She had a lumbar drain in, which is a catheter that you use to drain spinal fluid. And they took it out that day and just routine sent her spinal fluid to the lab. And when the spinal fluid results came back, the lab had some kind of error where they couldn't read part of the tests. The only thing that came back and was abnormal was that there was a white count, meaning that there was some inflammatory immune cells in the spinal fluid, which can be a sign of meningitis. But she looked fine. She didn't have any fevers. Her blood white count was normal. So I just kind of blew it off and was like, look, this was at Jackson, a county hospital. The lab makes errors there for sure. And so I just kind of blew it off and said, no, there's no way this lady has meningitis. This is nothing. And she looked fine all day long. And then suddenly in the middle of the night, literally from 1 minute to the next, became obtunded. Her pupils blew, and she died, within hours. Wow. So fulminant meningitis, I've never seen that before. Never seen it since. But it was kind of my first brush with the idea that, you can make a mistake and immediately someone pays the price for it. And, would it have mattered if I started on antibiotics earlier or something like that? Very possibly not. But still, you feel like you really hurt somebody. And I think you kind of have to thread the needle in this field between caring, but again, just not being paralyzed by fear of doing something like that. So that was a rough one. And I think we're all sort of psychologically built up to give a lot more valence to these negative emotions than we do to good ones. But there are a lot of great outcomes too. So one case that always sticks with me is, I think I was maybe a year into practice. This was during COVID, so everything was weird, as I'm sure you remember. And this girl came in, she was probably 25 years old, virtually quadriplegic. She was in a bed. She could move her arms and legs a little bit, but couldn't walk, couldn't use her phone, nothing. And we scanned her, and she had a very large benign tumor in her neck, pushing on the spinal cord. And I took her to the operating room, removed the tumor. Honestly, a fairly easy operation. And she was walking within about 2 days using a walker, and then came back to see me in clinic after a month walking. And I was like, do you feel off a little bit? She's like, no, I'm fine. Back to work.
Wow.
Like, perfect. So cases like that, you're like, doesn't get much better than that, you know?
Yeah,
You take somebody from being quadriplegic to normal within a month, that's pretty incredible. And then for me, I don't know why, but somehow anytime you restore vision to somebody is a huge deal. So there's two usual ways we do that. One is for pituitary adenomas, which are benign tumors in the pituitary gland. When you get there through the nose, that's a fairly easy operation, so I never get that much of a kick out of it, you know? But there's other tumors called meningiomas, which are also benign, but they can sometimes grow right underneath the nerves that control your vision. And taking those out is a challenge. Those are much trickier operations. You come from above through the skull. And I had a patient recently who came to clinic maybe a month after, and he was saying how for the first time he was able to do the New York Times crossword puzzle again.
Wow.
And he was saying how he was sort of sitting on like a float in his pool and doing his crossword, and he just realized that he hadn't been able to do that in like 6 months. So cases like that are incredible. And I think the big deal is just getting enough positive emotional energy out of those cases that you can make it through the dark times, which are invariably going to come.
Sure.
And I think there are people who have very high risk tolerance. I don't. If something bad happens, I'm devastated. So you just got to kind of really milk all the good ones for what you can, and then try to make it through the tougher cases. But I've definitely had, sleepless nights, whether it's before a case when you're trying to, think about exactly what to do, especially when I was starting out. The first 6 months or so, I would wake up at 3 a.m. before a difficult case and just couldn't fall back asleep. That went away, luckily. But even now, if there's a patient that I operated on, I'm a little worried about something, it's not easy,
Right. So when you wake up, are you reviewing the case, or what are you doing to suppress the anxiety?
So, I mean, and my wife will make fun of this, I'm very much not an anxious person. She's annoyed how unanxious I am generally. But there's something about, especially when I became an attending, in residency, you didn't get that much of it because at the end of the day, it's not your responsibility.
Sure.
But once it is your responsibility, it definitely weighs on you. And I don't think it's not healthy. I'm not actually getting anything out of, being up for 4 hours and thinking about the case. I'm not doing anything productive. And I think I've definitely gotten better at that, but I think it's just a human emotion. If you're, if you've got somebody else's life in your hands, you're going to care, hopefully.
Right, you care, yeah. No, that just reminds me of the famous Dr. Clifford, where he says, the anesthesiologist, who you work with many times, he says, never stop caring, and when it affects you, it's because you care. And I think we mentioned that earlier in this podcast, how you have the representation of someone who is very compassionate about your patients, your work, and the people around you that you affect. So don't lose that. Don't use that humanity, right? Because with all this technology and AI and whatever else is going to come down the road, quantum, I fear that it might suppress that, right?
For sure.
Because we're going to be so reliant on the technology and the decision making. You deal with patients' information, patients' data. So what sort of, if any, do you have discussions with yourself or your staff that is interacting with these patients and gathering all this information as far as cybersecurity is concerned and protecting that? I'm sure you're not, I'm sure you're privy to seeing that every day there's a new breach somewhere, some healthcare system. So is there any discussion in the office, or did anyone talk to you about this?
Not significantly. I mean, we're always reminded not to do anything stupid, obviously, like share your password or anything like that.
Sure.
But I can't say I spent a whole lot of time thinking about, protected health information.
Sure.
I'm also in a field where we don't deal with things like, psychiatric diagnoses or sexually transmitted diseases or stuff like that, where you're really worried about somebody else knowing about it. So I can't say I spent a whole lot of time thinking about it. And also, I think Epic and just generally all the healthcare software does a fairly aggressive job of keeping that stuff private.
Sure.
Like you said, there's always going to be breaches, but yeah.
Yeah, it's good to know. And lastly with that, are you using any AI software technology?
I'm not yet. I feel like I'm very behind the whole AI train there. It's interesting. I'm sure that's another thing. That's going to happen.
Right.
Back to our technology discussion. I mean, AI is going to take off for sure in fields like spine, where there's so much voodoo into deciding, specific approaches, which levels to treat, front, back, side. AI is definitely going to have a huge impact on that.
Something, right. All right, well, then we don't want to sign off on quietness. Let's play ourselves out, okay? All right, well, we appreciate you watching the show, this episode. My guest here, Dr. Buttrick, and we are signing off with we're going to basically serenade our guests, the viewers here. We appreciate you watching the show. Of course, if you can follow, share this video. We are a self-funded podcast, so we are looking for help. We're looking for subscribers, and this has been an amazing opportunity. We do appreciate you, Dr. Buttrick.
Thank you.
You are amazing. And here we go. We're gonna serenade you now. Here we go. Ready? 1, 2, 3.
Whoops.
Well, that is our episode. We do appreciate you watching. This was our Halloween edition. We appreciate our guest, Dr. Buttrick, for being here and sharing his amazing story. I hope he inspired some people. He answered some questions from the chat. We are a new podcast, so we do appreciate if you could share this video. We're on Facebook, Instagram, YouTube, Spotify, iTunes. We're going to continue to grow. If you're interested in being on the show, you can contact me. I'll have some information below where you can reach me. Again, this is the CyberHealthPodcast. I'm Napoleon Dynamite. We'll see you on the next episode. Take care.